I'm really happy that we can both present together the findings of our study, and I have a little bit of background to help set it up. But you did a great job sort of setting the scene, and we'll be going through some of what you've said in a little bit more detail. But that was fantastic. So we're going to talk a little bit about Sleepwell and the study itself. Yawns NB was the study name, and the icons at the top kind of show the funding of Sleepwell over the years, as well as Yawns NB, where that funding came from. And then there's a variety of names on the list there in terms of those who have supported either the development of Sleepwell or the research that we have been conducting over the last several years. So hopefully by the end of this, we can talk a little bit together about what really can help align insomnia care in New Brunswick with guidelines. So as Pam mentioned, it's a little bit out of sync right now, and I think we have some ideas for making things line up a little bit better with reduced use of sedative hypnotics and increased access and use of something called cognitive behavioral therapy for insomnia, which I'll talk about. So I think everybody actually does know what insomnia is. Probably everybody has experienced insomnia from time to time. So the difficulty of achieving sleep, getting to sleep, it's challenging sometimes, or getting back to sleep if you wake up in the middle of the night, and then having next day distress or functional impairment associated with that. So that's kind of the simple definition of it, but it reaches much further than that in people's lives and in terms of our healthcare system and economics. So it's very common, whether it's just the symptoms of insomnia or the diagnosis of chronic insomnia itself, it's very common. And chronic insomnia is defined as having those symptoms on most nights for 3 months or longer. And for people who live with chronic insomnia, very often it's much longer than that. And the people who are most burdened with insomnia tend to be older women, older adults in general, and those who live with chronic other health issues, mental health issues, and physical health issues. And I just want to make a really important distinction. It's a two-way street. Insomnia is associated with these illnesses, but it also causes an increase in these illnesses. And that was the basis of a recent economic analysis by Chaput out of the University of Ottawa a few years ago. And their group identified the cost of insomnia across Canada in terms of direct costs as almost $2 billion per year. And when we look at what the direct costs are, they're related to the extra costs or excessive costs associated with very common conditions that we're all familiar with. So the insomnia itself has a attributing effect, if you will, on diabetes to the tune of $752 million. If there was no insomnia, you would be saving all of that money. Depression, same kind of thing, $700 million with less depression, less direct costs, and we can reduce the rate of depression with reduced rate of insomnia. Cardiovascular disease, cognitive decline, hypertension, all of that adds up to about $2 billion directly linked to insomnia in and of itself. And their data, they took a pretty moderate approach in suggesting a 5% decrease in insomnia symptoms, not even a reduction in diagnosis, but in insomnia symptoms from 23.8%, which was what they had identified as the existing rate, down to 18.8% would result in an estimated $353 million across Canada in avoided costs. And that to me seems quite modest in its goal. Moving over to sleeping pills, the rate of use of sleeping pills increases at a steady rate across the years. And so if you sort of look down and see the 60 to 69 threshold in terms of age, we can see that we're pushing into the 20% range and higher for use of sedative hypnotics, in this case, benzodiazepines and Z drugs, and we'll talk about those in a moment. But here's the big story, the really important story for us to take away and really think about. The average rate of chronic use of sedative hypnotics in Canada is 8% for people 65 years of age and older. It's almost 3 times that in New Brunswick. There's other provinces that have higher than expected rates, and they seem to be clustering in Atlantic Canada, as you can see here. And there seems to be a few provinces out west that have substantially lower rates. The real common question is why? And the answer is not absolutely clear. When we look back over time, we can see that some areas of Canada have reduced, and I haven't put everything up here because it gets a little bit messy, but you can see that Saskatchewan started in 2011 with a low rate, and it lowered the rate of sedative hypnotic use in Canada, the benzodiazepines and Z drugs, over the following 8 years. In New Brunswick and Newfoundland, there was no budging. It continued to be high, and it stayed high. So what are we talking about? What kind of sedative hypnotics are we specifically talking about? So there may be some names that you're familiar with. So the most commonly prescribed sedative in New Brunswick and really across Canada is zopiclone. But other ones are also quite common. So you'll see lorazepam, a benzodiazepine. So this is a benzodiazepine, and all of these are benzodiazepines. And up here are Z drugs. They kind of do the same thing pharmacologically. So we call them benzodiazepine receptor antagonists, or over here, BZRAs. So I'll be talking about BZRAs, but then there's other medications and substances, as you can see down here, that people resort to help them fall asleep. So I'm really classifying all of these together as sleep aids or sleeping pills and substances collectively. When it comes to the adverse effects of sedative hypnotics, broadly speaking, or more focused on the Z drugs and benzodiazepines, there's quite a long list of concerning serious adverse effects. And most of those adverse effects are quite familiar to healthcare providers. There's some that are not. For example, pneumonia and other immune-related complications. COVID was related hospitalization as another example. But for the most part, people would say they know of these side effects, but they don't seem to have the impact that we're hoping in terms of reducing the use by knowing those adverse effects. There have been a variety of campaigns to reduce the use of sedative hypnotics that have really been focused on the prescribers and the pharmacists to help reduce the use. So Choosing Wisely Canada has made it very clear, and this is really an international effort to reduce the use of benzodiazepines and other sedative hypnotics in older adults. And this campaign, I think, was initiated around 2013. So we've had a long time with a lot of efforts to try to reduce uses of these medications in the past. We're taking a slightly different approach. We're sharing information in a way that's not exactly how it's been done in the past, and we're sharing it directly with the public and with people who are taking sedative hypnotics, and we're partnering it with images that have a greater impact and meaning to individuals, such as this. They can have cognitive impairments, including memory reduction, reduced alertness, thinking problems, and including cognitive decline in people who are taking benzodiazepines and Z drugs. We know that they're associated with an increased risk for falls and serious injuries, including more fractures. And we're particularly concerned about hip fractures as being a concern. And as I've mentioned before, I'll just keep going. There's information shared by prescribers with their patients that these medications can potentially impair driving, and there's actually more that we can say about that. So there's good data that shows that zopiclone, New Brunswick's #1 prescription medication for insomnia, is associated with next day driving impairment at the same level of a blood alcohol content of 0.08. So this is 11 hours after your dose. It's about the same effect as if you've had 2 to 3 drinks of alcohol a half an hour beforehand. So this is very substantial, and it's not the way information is typically shared. But when I present it this way, it has a much different impact. So we know that the concerns are worldwide. Everybody knows about them. But what most people don't know is that sleeping pills are not first-line therapy for chronic insomnia. They're only to be used after cognitive behavioral therapy for insomnia has been tried. And so that's not what happens. So we're not following guidelines in this part of the country and really anywhere in the country right now. So our approach is to try to increase awareness of CBTI and access to CBTI. So what is CBTI? It actually is a 6-week program that focuses on a few specific sleep-enhancing techniques. And so this is just an image of what the program can look like. People doing a sleep diary for the 6 weeks and then learning how to layer on different sleep enhancing techniques over the 6 weeks. Once the 6 weeks is over, the program's over, it ends. It's not like sleeping pill use where you're taking it for years and years, a 6-week program. So the components are listed here, have been studied unbelievably well. I would say CBTI is better researched than most medications that get onto the Canadian market. We have the information on our website, and there's hundreds of citations of people doing well on CBTI, whether they're younger or older, whether they have a comorbid mental illness, comorbid physical illness, or a variety of illnesses. So it's really well established, and that's why it's first-line therapy. What we're proposing is to drive people out of primary care for their insomnia management, chronic insomnia management, effective first-line therapy self-care approaches. We do know that some people will need CBTI offered by trained CBTI providers or behavioral sleep specialists, but we know that probably the majority of individuals can do well using a self-care approach. So reducing the burden on the healthcare system by making available self-care interventions. So I'll just quickly tell you what Sleepwell is, and then we'll talk about the study. So Sleepwell was developed quite a few years ago as a research and knowledge mobilization program with 2 main objectives: to improve insomnia outcomes with CBTI and to reduce sleeping pill use and the related harms. We have a website that provides information in a way that is trying to be engaging and behavior change motivating, if you will. And we have a whole variety of tools to support the process of reducing and stopping chronic use of sedative hypnotics safely and permanently. We also have information about CBTI, so we're not suggesting take away a treatment, but we're saying replace a treatment with something better. So introducing CBTI, letting individuals become familiar with it, and offering a variety of tools that support individuals going through CBTI in and of itself. And we have 1-page handouts that compare CBTI with sleeping pills to help with that motivation. So we know CBTI works based on its very extensive evidence base. What we didn't know is Sleepwell making a difference? Is it supporting individuals reducing the use of sedative hypnotics, improving CBTI access, and having better sleep outcomes? So with the Healthy Seniors pilot projects, we applied for it and were funded to run the YONS NB study. So Your Answers When Needing Sleep in New Brunswick was a 3-arm minimum contact pragmatic 6-month trial that was with random allocation. If you were randomly allocated to the Sleepwell intervention, this is what it was. This is all it was. It was nothing more than this. You received a package in the mail that when you opened it up, it had a cover letter and 2 booklets. When we look at the booklets from a behavior change perspective, the cover letter had 3 behavior change techniques embedded in it. The How to Stop Sleeping Pills booklet has 23 behavior change techniques embedded in it, and 19 in the second booklet, How to Get Your Sleep Back. So we really rely on the behavior change theory and the behavior change wheel to develop our resources, if you will. And this comes from work that Andrea Murphy, who is co-developer of Sleepwell and part of the research team, she spent time with Susan Mickey at the University College of London, developing her understanding and utility of the behavior change wheel and the behavior change techniques taxonomy to inform our overall approach, which is to improve individuals' capability, opportunity, and motivations for the desired behavior change. So just a sneak peek into what the booklet looks like on the inside. This is not all of the pages, but take the quiz about sleeping pills. Those quiz answers are hopefully making you feel a little uncomfortable with ongoing long-term use of sedative hypnotics. Some dangers around sleeping pills were articulated and illustrated. Information about the sleeping pill vicious cycle, why it can be difficult to come off of it, and how to come off of it slowly. And then with booklet 2, the answer to getting a good night's sleep without sleeping pills is provided. So encouraging information and giving individuals access to CBTI techniques and specific programs that support you going through an official so-called CBTI program. So let's now quickly go into the study itself and our findings. So we had at the top, I think it's 565 individuals in the study that were randomly allocated to one of the three groups. The average age of the participants was 72. And the message here is that they're all independent, community dwelling, living alone. We're not looking at individuals who are in long-term care or have dependence on the care from others for their health. Most of them were driving, some less than others, but most participants were driving, had a range of health conditions that you would expect in this age group, as well as regular medication use. But one of the most important findings at baseline was that our participants had an average duration of benzodiazepines or Z drugs of over 11 years. 31% of them had a fall in the past 12 months. And of that group, about 1 in 5, the fall caused a serious injury. So the three groups that were studied, as Pam mentioned at the start, were the Sleepwell group, who received the package I've just described. The EMPOWER group, they received a different package that had been studied in Montreal several years before, which was also focused on reducing and stopping benzodiazepines specifically, and it was demonstrated to be quite effective and made quite a splash. And then the third group is like our placebo group, the treatment as usual group, so no intervention. And in each case, there was no contact with the study participants after sending out the packages to them. We followed up at 6 months to assess their treatment outcomes. So this study got published in JAMA Psychiatry back in September, late September of 2024, and here's the main result. So a substantial number of individuals were able to stop their, on average, 11 years of sedative use based on receiving the package itself. The package encouraged them to visit with their family doctor or pharmacist to discuss the process of reducing and stopping. Much of the study was happening during the pandemic, so quite a bit of this actually happened when people followed the guidance of the booklets themselves. Some were interacting with their pharmacist more so than with their physician, but some were doing it also on their own. So 1 in 4 to 1 in 5 were actually able to stop or reduce their medications. So almost 50% of individuals who received the Sleepwell package stopped or reduced their long-term use of benzodiazepines and Z drugs, and did not replace or substitute it with a different or other sedating agent, which is found to happen quite a bit when people are pushed to stop taking one sedating agent. They often switch to another sedating agent. The EMPOWER intervention was also effective, but less effective than the Sleepwell intervention compared to the treatment as usual group. And we found a few other additional benefits that were only found with the Sleepwell intervention. So we were really pushing with booklet 2, the uptake of cognitive behavioral therapy and its sleep-enhancing techniques. And so the Sleepwell group had the highest use and had better sleep outcomes than the EMPOWER group or the treatment as usual group. And what was really interesting is if the group if the subgroup of the Sleepwell participants did stop their sleeping pill, they had about 27 minutes of getting to sleep faster. So they were getting to sleep faster even though they stopped their sleeping pills. And if they were part of the subgroup that didn't stop their sleeping pills but received the Sleepwell group, they also had about 26 to 27 minutes onset of sleep faster than prior to coming in the study. And that wasn't seen with the EMPOWER group, and it wasn't seen with the treatment as usual group. Sleep efficiency improved with Sleepwell, insomnia severity improved, daytime sleepiness improved. And when you take away medications like benzodiazepines and Z drugs, which are also used for anxiety, there is a question that maybe harms might happen because of stopping these medications. So we were looking at quality of life and anxiety, and with the Sleepwell group stopping these medications or not stopping these medications, there was no worsening of anxiety or quality of life. And in fact, it trended towards improvement. We reached out to family doctors to ask them about what they thought of Sleepwell as we were conducting this study. And the family doctors that we reached out to were family doctors of study participants. So they didn't know that their patient was in the study, but we asked those individuals who were in the study to identify their family doctor, and then we sent packages to all the family doctors after the last patient was in the study to ask them about what they thought about the intervention. So we had that investigation published as well last year. And I won't go through it all, but I'll just give you a bit of a quick overview. We asked the family doctors about their overall impression of benzodiazepines and Z drugs and sedative hypnotics for the use in insomnia. It's not shown here. And then we asked them about their overall agreement or acceptability of Sleepwell as a direct-to-patient intervention. Not, would you give this to your patient, but would you like somebody else to give this to your patient as part of a health promotion campaign? And so just to give you an example of some of the responses, I support my older patients receiving the Sleepwell materials, so there was 100% agreement with that statement. A mailed health promotion campaign with Sleepwell will excessively strain my practice. There was strong disagreement with that statement. Sleepwell materials are a credible way to promote sleep therapy treatments for insomnia. There was strong agreement with that. So what you see behind is all of the statements, and when we look at them based on the theoretical framework of acceptability, which has 7 different domains, you can see that overall, there was strong acceptability across all domains regarding the Sleepwell intervention, which made us feel quite confident that this would be an adequate and acceptable intervention when thinking about it from a public health intervention or a health promotion intervention, as opposed to an intervention where we're expecting the healthcare provider to do it. And ultimately, when speaking with healthcare providers like family doctors, they say that deprescribing sedative hypnotics is very challenging for them. To have the conversation is very time consuming. And this would be seen, the Sleepwell intervention would be seen as a facilitator to make the process more efficient and positive going forward. And with that, I'll pass it over to Cameron to talk about the cost benefit analysis that is underway.
Thank you, David. So I'll go over the cost benefit analysis we did for Sleepwell over the next few slides. So next slide. The goal of the cost benefit analysis was to approximate the costs we save the healthcare system if the discontinuation of benzodiazepine receptor agonists, or BZRAs, resulted in fewer falls or fall-related injuries. We focused on the link between BZRAs and falls or fractures because they're costly health outcomes, and there's plenty of research that supports this relationship. Our analysis was scaled to the New Brunswick population of older adults identified as chronic users of BZRAs. We focused on the healthcare payer perspective, which means that we only consider direct healthcare costs. So cost to hospitals, cost for physicians, laboratory tests, etc. We picked the time horizon to be 1 year, which means that we expected falls or fractures due to BZRAs to occur before the end of the year. Next slide. The data we used were retrieved from the literature. For costs, we used 2 studies that focused on patients presenting to emergency departments in Ontario and British Columbia. Both looked at costs in detail based on the services needed to treat that patient. We used Canadian estimates of the baseline risks of falls and fractures to approximate our control scenario, which tells us how many falls or fractures we'd expect in the population in the absence of taking BZRAs. These data were taken from the Canadian Chronic Disease Surveillance System, the CCDSS, and the National Ambulatory Care Reporting System, or NACRS. We looked to systematic reviews and cohort studies for the estimates of the odds of a fall or fracture, which tells us specifically the magnitude of the relationship between BZRAs and the outcome of interest, like a fall or fracture. And together with the baseline risk, the odds ratio and the baseline risk, when combined, they'll give us what's called the risk difference, which is what we're interested in this economic evaluation. And finally, the cost of Sleepwell and the rate of discontinuation were retrieved from the Sleepwell research team. So, the discontinuation rate would be 18.7% that we'd expect to stop due to Sleepwell, which turns into 5.3 mailed packages for every person that discontinues BZRAs. And the cost of Sleepwell per person per each year is roughly $20. Next slide, please. So in the population of 16,000 or so chronic users of benzodiazepine receptor agonists, or again, BZRAs, we anticipate 65 to 198 fewer fall-related emergency department visits, 9 to 21 fewer fractures of any kind, and these fractures included fractures to the spine, humerus, forearm, or pelvis, and 6 to 12 fewer hip fractures specifically. In red, we display the cost of Sleepwell for this population, which is roughly $332,000 for this population within 1 year. And that's just to send the package to everyone. When we subtract the costs avoided from the costs, when we subtract, the costs avoided due to falls or fractures, when we subtract that from the cost of Sleepwell, we see that Sleepwell should save the healthcare system between $700,000 to $2.8 million in avoided falls, $100,000 to $700,000 in avoided fractures of any kind, and $100,000 to $600,000 in avoided hip fractures. Next slide, please. Our results support the cost effectiveness of Sleepwell, which is a low-cost intervention that avoids serious and costly health issues. Some strengths of this economic evaluation include its scalability to, or it demonstrates that Sleepwell is scalable to areas with limited access to healthcare services like rural and remote areas. As well, we tested the cost effectiveness of Sleepwell using high and low estimates of odds ratios, meaning that our results are robust to many different scenarios. For limitations, one of those limitations includes our focus on only falls and fractures. Like David talked about earlier, insomnia is related with many health issues that we didn't explore here, such as depression, diabetes, cardiovascular disease, and car accidents. So it is possible that our cost-benefit analysis represents a conservative estimate of the potential benefit of this program. And I'll turn it back over to you, David. So thank you very much. David, I think you're muted there.
All right. It's helpful now for me to not be muted. So I'm just going to wrap it up with the key points that hopefully we've made clear as we've gone along. So insomnia directly increases the cost of physical and mental health care. Sedative use also increases the associated costs. It increases with age, so it's really costs associated with older age. And CBTI is first-line therapy, so our high rate of use of sedatives isn't actually justified based on following guideline therapy for most effective and safest therapy for insomnia. The rate of chronic use of sedatives in New Brunswick is approximately 3 times higher than the average Canadian rate, and it hasn't changed over the last 10 to 15 years. For every 5 mailed Sleepwell packages, we have about 1 person stopping the long-term sedative use, a very simple and scalable intervention. It was also associated with better sleep outcomes, and as Cameron has reviewed, it's cost-effective. So where I want to leave this is really talking about what kind of steps do we need to take going forward. So I tend to think of it as a public health campaign approach, so as a next step. So focusing more broadly on the importance of sleep, looking at specifically insomnia as the most prevalent sleep issue, and then how we manage it, talking about CBTI as opposed to the use of sleeping pills in the management. And in doing this, it's predicted to reduce healthcare costs across the province, sedative dependence, and significant harms, while having better sleep, mental, and physical health outcomes. And I would say that an initiative like this really does strongly align with healthy aging and aging in place as a provincial priority. And just to let you know, I can't move my slides yet. Okay. Just to let you know, the proposal could be anything. So this is just almost tongue in cheek, but just to let you know how I'm thinking of it as a health promotion campaign for older adults who live in New Brunswick. We use the name for our study as Your Answers When Needing Sleep in New Brunswick. It actually could be, you could call it something like that as your educational program. Again, it's not focused only on sleeping pill use. It's more broader than that. And the reason I mention that is we're working with colleagues in Iceland just as of late who have reached out to use the Sleepwell intervention for their campaign to reduce the overuse of sedative hypnotics. When they compare themselves with other Nordic countries, Iceland is substantially above the other Nordic countries in their use. They see the Sleepwell intervention as part of their solution to that. And we've been working with them. So we developed a pamphlet that would be shared with the public as one mechanism. They also have plans for social media and main media interviews, TV, radio spots, and other ways to communicate to the public about the campaign about sleep as being important, insomnia is a common issue, sleeping pills may not be the best option, and CBTI is something we don't have a lot of people knowing about and accessing, and we would like to change that. So this is just to exemplify how things have moved quite quickly, actually, in Iceland, and it's very similar to what I've been thinking about for New Brunswick.